Doctor Miguel Farfán, presidente de Aspefam, la Asociación Peruana de Facultad de Medicina. Bienvenidos a esta conferencia de manejo hemodinámico del paciente con COVID en estado grave, a cargo del doctor Jean-Louis Teboul de Francia, que es organizado por la Sociedad Peruana de Medicina Intensiva en sus múltiples actividades académicas por esta pandemia y con la colaboración de Aspefam. Como ustedes saben, ya tenemos casi 10 millones de personas afectadas en este momento en 188 países, casi medio millón de fallecidos, lamentablemente, 495.000, y el Perú se encuentra en el 6º lugar en casos clínicos, en cuanto a casos confirmados, con más de 1/4 de personas, 272.000, y 9.939 fallecidos. Sigue siendo una enfermedad de difícil manejo, en especial por los recursos con los cuales contamos, que son limitados por la cantidad de pacientes. Sin embargo, ya conocemos mucho más de su comportamiento y un poco más de tratamiento, ¿no? Y sobre todo cuál va siendo el más recomendado y algunos que llevamos dejando en el camino. Esta reunión la modera el doctor Jorge Watanabe Noyi, él es médico intensivista, él es formado en el Hospital Rivaliati por la Universidad Nacional Mayor de San Marcos, él es médico asistente en la actualidad de ese hospital en cuidados intensivos, es jefe de la UCI Centenario y es secretario de Acción Científica de la SOPEMI, por lo cual justamente estamos acá un poco reunidos. Antes de dar la conducción a Jorge, voy a darles algunos alcances. Vamos a tener ahora traducción simultánea. Acá el doctor Jorge Cabrera, que es médico intensivista del Hospital Sábado, ya tiene la gentileza de apoyarnos en este evento. Ustedes abajo en su panel de Zoom tienen un icono, que es un planeta que dice interpretación. Ustedes van a poder escoger el idioma español o el idioma inglés de esta conferencia. Luego de la conferencia, el doctor Teboul va a ver las preguntas de los participantes. Este es el icono de preguntas y respuestas, ustedes van a darlo por ahí. Y de algunos invitados, sobre todo SOPEMI y sobre todo el Consejo Directivo que está presente, y algunos presidentes de la sociedad que se nos van a unir en el camino. Al terminar, el presidente de SOPEMI hará unas secuencias finales y luego el doctor Farfán hará el cierre del evento. Y al término de todo esto va a haber una encuesta de satisfacción de esta conferencia, que es un poco la asistencia de los participantes para el tema de certificados. Entonces dejo en la conducción al doctor Jorge Watanabe. Jorge.
Sí. Muy buebuenas tardes amigos intensivistas del Perú, amigos intensivistas sudamericanos. En primer lugar, mi agradecimiento por la gentileza de aceptarnos esta ponencia al doctor Jean-Louis Teboul, médico renombrado, muy amigo de SOPEMI, y colaborando, digamos, en la actividad académica para el adecuado manejo de esta pandemia. Sabemos que el soporte hemodinámico, digamos, es el segundo pilar de manejo de los pacientes críticos. La parte es respiratoria, pero la parte hemodinámica es un aspecto muy importante. Vamos a comenzar presentando al profesor Teboul, ya es conocido por muchos de nosotros, es profesor de terapéutica y critical care medicine de la Universidad del Sur de París, es miembro de la Sociedad Europea de Cuidados Intensivos, editor del Anual del Intensive Care Europeo, y asimismo profesor, digamos, en lo que es cuidados intensivos del Hospital Le Kremlin, Bicêtre, París. Y él nos va a disertar en esta ocasión todo lo que es los aspectos hemodinámicos en lo que es el manejo del paciente COVID grave. Adelante, profesor Teboul.
Thank you very much for this introduction. So I would like first to thank the SOPEMI for this invitation, for this lecture. I am very happy to participate in this webinar. And I would like also to say hello to all my friends in Peru, but also in the rest of Latin America. I have a lot of friends in your continent, and I know that right now it is very difficult because of the pandemic, the COVID-19 pandemic for all the Latin America. It was also difficult in Europe, as you know, and now it is better, I would say better in my country, but I know that in Peru and the rest of Latin America, it is very difficult. So I would like to say that we are with us, with you, and I hope that this pandemic will finish shortly. So Having said that, I would like to emphasize on the hemodynamic management of COVID-19. And I have first to declare that I am a member of the Medical Advisory Board of Göttingen, Belgium. As you know, in COVID-19, the most frequent event is ARDS. And shock is not present in all cases. But in this Chinese study, the frequency of shock, the rate of shock, the incidence of shock was 30% for the whole population. In some other studies, it is between 20 and 25%. It depends. But there are some people with shock, and we have to take into account this event to manage patients. So the question finally we have to face is the presence of hemodynamic instability. If there is no instability, there is no need of...
El modo de presentación, Jorge.
Sorry? Can you hear me? Can you hear me? Hello? Can you hear me?
Sí, puede continuar.
I can continue. Okay. I don't know. Can you hear me or not? Sorry.
Okay.
Que continúe, por favor.
Okay.
Continue.
Sorry.
Okay.
Si no se puede, Jorge, no se puede. Así.
Parece que no te escucha, Coco. Yeah, okay, it's okay.
Can you hear me now? Okay.
Sí, yes, continue,
okay.
Please.
Okay, because I have a technical problem. Okay, I was saying that if you have no hemodynamic instability, there is no need of any treatment. But the question is the presence of hemodynamic instability. And there are four mechanisms which can be responsible for this hemodynamic instability. Vasoplegia, hypovolemia, right ventricular failure, RV failure, and myocardial injury. First, RV failure, right ventricular failure. This study, published in Circulation in this year, showed that in 100 consecutive patients with COVID-19, the presence of RV dysfunction or RV dilatation was 39%. So they performed systematic echocardiography within 24 hours of admission. And many patients had anomalies, and the most frequent was right ventricular dysfunction. Interestingly, 20 out of these 100 patients experienced clinical deterioration, and 12 of them had RV dysfunction deterioration, meaning that this anomaly, RV dysfunction, is very frequent in COVID-19. And there are different mechanisms responsible for RV failure in COVID-19. The first one, of course, is the presence of ARDS-related pulmonary hypertension. As you know, there are many reasons to have pulmonary hypertension in ARDS: hypoxic vasoconstriction, mediators-related vasoconstriction, perivascular edema, microthrombi in pulmonary vessels, and also microvascular remodeling. So many reasons to have pulmonary hypertension. But also in ARDS patients, we use mechanical ventilation, and we can have mechanical ventilation-related pulmonary hypertension due to high transpulmonary pressure and also sometimes due to hypercapnia. In addition, we also have the presence of massive pulmonary embolism, and this is a frequent event in COVID-19. This study, which will be published soon in Circulation, looked at the presence of pulmonary embolism in COVID-19 patients. And they took 107 consecutive COVID-19 ICU patients with pneumonia. And they found that 21% of them had pulmonary embolism. And this was high compared to the presence of pulmonary embolism in other events. For example, they compared to the same period in 2019, and they had almost 200 patients hospitalized during this period, and they found only 6% of pulmonary embolism. So COVID-19 is associated with a frequent presence of pulmonary embolism. They also compared to patients with influenza, the normal flu, hospitalized last year, and they found only 7% or 7.5% of pulmonary embolism in this kind of patients. So meaning that COVID-19 is especially associated with pulmonary embolism. And how to detect this right ventricular failure? Of course, with high CVP, and it is important to measure CVP, central venous pressure, in COVID-19 patients, but also high troponin. And in this study I already talked about, they found that 20% of patients had elevated troponin. And interestingly, 10 of them, 50% of them, had isolated RV dysfunction. So RV dysfunction is able to be associated with elevated troponin without any LV dysfunction. Of course, the main way to diagnose right ventricular failure is echocardiography, of course, and this is important to perform as soon as possible echo to diagnose RV failure. But when you have the presence of RV failure, it is important to treat some patients. Of course, you can give a specific treatment for pulmonary embolism, but sometimes you use prone positioning. And prone positioning for ARDS, of course, is also important for RV dysfunction. This is a study we performed some years ago with Mathieu Josiac and Xavier Monet. We included patients with ARDS. They were ventilated with a tidal volume of 6 ml per kilogram and a low level of PEEP at the beginning. And we prone the patient and we adjusted PEEP to have the same plateau pressure, 30 centimeters of water. And we measured hemodynamics with Swan-Ganz catheter, but also with a PICO and also with echo. And what we found is that when we prone the patient, we had a decrease in the gradient between the mean pulmonary artery pressure and POP. and also a dramatical decrease in the pulmonary vascular resistance. At the same time, with echo, we found a decrease in the RV endosuchuria over LV endosuchuria ratio, which is a marker of RV dysfunction, and also a decrease in the left ventricular eccentricity index, meaning a decrease in the left, the septal shift to the left, meaning that with prone positioning, we improved RV dysfunction. And also in these patients, we observe an increase in cardiac index. In other words, when you prone the patient, you can improve RV function by reducing RV afterload in this kind of patients. Of course, this study was performed before COVID-19. Nevertheless, probably the same results can be found with COVID-19 patients and ARDS patients. Therefore, prone positioning is important for patients with ARDS to improve hypoxemia, but also to improve RV dysfunction. Myocardial injury, another event in the course of COVID-19. And there are many mechanisms responsible for myocardial injury. One of them is the direct action of the virus, viral myocarditis. And this can happen in the early phase of COVID-19. Also, we can have a mechanism due to a cytokine storm, cytokine release, which is frequent in COVID-19 ARDS patients, especially in the second phase of the disease. And this can create some acute myocardial injury, but this can occur in the second phase of COVID-19. Also, the presence of microvascular thrombotic injury into the myocardium. This can also happen in COVID-19, and other mechanisms also are possible. What about clinical manifestations? We can have acute coronary syndrome, like STEMI or non-STEMI. We also can have some acute myocardial injury without obstructive coronary artery disease. We can have arrhythmias, and also we can have cardiogenic shock. All these manifestations are possible in COVID-19. Of course, we have to diagnose myocardial injury by ECG, by cardiac biomarkers like BNP or troponin. And before, I spoke about this study where troponin was measured in a series of 100 consecutive patients with COVID-19. But interestingly, when troponin was elevated in 20% of cases, 6 of them only had isolated LV dysfunction, diastolic dysfunction, and only 3 of them had LV systolic dysfunction. Therefore, troponin is more a marker of RV dysfunction than LV dysfunction. And the best marker, of course, of LV dysfunction is the presence of LV dysfunction at echocardiography. And we have to perform echocardiography as soon as possible again. And using echocardiography, this study showed that in a series of 100 consecutive patients, 16% of them had LV diastolic dysfunction, and only 10% of them had LV systolic dysfunction. But of course, this study examined the patients at the beginning of the hospitalization, and sometimes LV dysfunction, systolic dysfunction can occur later due to the cytokine storm. What about hypovolemia now? As you know, some recommendations were published recently by the Surviving Sepsis Campaign. This is These recommendations are about COVID-19 only, and they recommended in the case of acute resuscitation of COVID-19 patients with shock, a conservative over a liberal fluid strategy. It was a weak recommendation. Nevertheless, it is important. But I don't disagree, but I don't fully agree with this recommendation, because at the beginning of COVID-19, the presence of hypovolemia can occur, and especially during the first hours of hospitalization, due to dehydration, due to high fever, to fluid losses, and also due to a decreased water intake in the previous days, of course. And sometimes also later, we can have a cytokine storm and the presence of sepsis. And this can result in capillary leakage and absolute hypovolemia, but also can result in increased venous capacitance, and which lead to relative hypovolemia. So hypovolemia can occur during sepsis, during COVID-19, even in patients with ARDS. Also, we have coagulopathy, which is a frequent event in COVID-19 with a high risk of thrombosis. And also we can have ARDS, of course, which is characterized by endothelial cell damage, and this can result in lung capillary leakage, but also in VQ mismatch. And lung capillary leakage also can result in VQ mismatch. And VQ mismatch can also be created by thrombosis of the microvessels in the lungs. And therefore, this can result in severe hypoxemia. So severe hypoxemia can be the result of VQ mismatch directly due to lung capillary leakage, but also due to thrombosis in the microvessels. So hypovolemia can create low blood flow, low cardiac output, which can result in multiple organ failure, but also low blood flow can increase the risk of thrombosis. And the risk of thrombosis can also create multiple organ failure. Also, low blood flow can result in low PVO2. If you have low cardiac output, you can have low PVO2. And in the presence of high pulmonary shunt, this low PVO2 can result in hypoxemia. So it is more complicated than we can imagine at the beginning. Therefore, if you give fluids, of course, you can increase the lung capillary leakage and you can aggravate hypoxemia. But on the other hand, if you give fluid, you can decrease the risk of thrombosis. You can also decrease the PVO2 effect, and you can decrease the presence of multiple organ failure. So there is probably a balance between the benefit of fluid administration and the risk of fluid administration. And this is what we have to deal with. We have to predict this benefit-risk ratio of fluid administration in this particular event of COVID-19. To assess the benefit, the numerator, we have to assess the degree of fluid responsiveness. To assess the risk, worsening of lung edema, we have to assess this, the indices of lung tolerance of fluid infusion. What about the numerator, the benefit, the degree of fluid responsiveness? As you know, not all patients are fluid responsive in the ICU. Only 50% of patients respond to fluid administration in terms of increasing cardiac output. And so we have to predict this fluid responsiveness. And now all the international societies, including the Surviving Sepsis Campaign guidelines dedicated to COVID-19, recommend or suggest to use dynamic over static parameters to assess fluid responsiveness. When we speak about dynamic indices, we can speak about heart-lung interaction indices or passive leg raising test. Heart-lung interaction indices are usable in case of mechanical ventilation, which is the frequent case in COVID-19. And the most popular heart-lung interaction indices, a series of variables, are respiratory variation of stroke volume indices, like pulse pressure variation or stroke volume variation. You know that when you have a high pulse pressure variation, you know that pulse pressure is the difference between the systolic and the diastolic pressure. And during mechanical ventilation, when you have a high pulse pressure variation, it means that the heart of the patient is operating on the steep portion of the Frank-Starling curve, therefore on the preload responsiveness portion, and therefore the patient can improve with fluid administration, and cardiac output can increase with fluid administration. On the other hand, when pulse pressure variation is low, it means that the heart of the patient is operating on the flat portion of the Frank-Starling curve, and therefore the patient will not respond to fluid administration. And in the past, in patients with sepsis, with Frédéric Michard and others in my unit, we showed that pulse pressure variation PPV was far better than the cardiac feeding pressures, like central venous pressure and POP. But there are many conditions where we cannot use pulse pressure variation or we cannot use stroke volume variation. And these conditions are listed on this slide. And fortunately, we have other tests to overcome these limitations. And first, we have an expiratory occlusion test, which is also usable in case of mechanical ventilation. This test consists in interrupting the ventilator at end expiration, and this for 15 seconds. And this can create a transient increase in venous return and preload, and this can serve as a preload challenge. And therefore, we can identify fluid responders by patients who increase their cardiac output during the test. And what is important is the duration of the test, which must be at least 15 seconds. And also what is important is to use a precise and real-time cardiac output monitoring. And this recent meta-analysis we performed with Francesco Gavelli and Xavier Monet showed that in 13 studies, the summary area under the row curve of the prediction of fluid responsiveness using this end expiratory occlusion test was 0.91 with a good sensitivity and good specificity. And we found a cutoff value of 5.1%. So when you have a response of cardiac output higher than 5%, you can presume that the patient will respond to fluid infusion. It is a very easy test to do, to perform, because it is very simple to use by just pressing a button on the ventilator to interrupt the ventilator for 15 seconds. And also in ARDS patients, in patients with low compliance of the respiratory system, less than 30 ml per centiliter of water, in this study with Xavier Monet in the past, we showed that this end expiratory occlusion test was better than pulse pressure variation to predict fluid responsiveness. Another test which is usable in patients with ARDS ventilated with a low tidal volume is tidal volume challenge. We know that in case of low tidal volume, which is the case for COVID-19 patients, there is some false negative cases of pulse pressure variation, meaning that sometimes pulse pressure variation is low, but the patient is fluid responsive. So we cannot use PPV in this condition, but we can use the increase, the change in PPV during a tidal volume challenge. In this study, we performed with Sheila Mayatra from India, from Mumbai, and other colleagues from Mumbai. We proposed to increase tidal volume from 6 ml per kilogram to 8 ml per kilogram during 1 minute only. With 6 ml per kilogram, PPV was not able to predict fluid responsiveness reliably. This is the area under the rocker, which is not satisfactory enough. But when we increase tidal volume, now the value of PPV is far better to predict fluid responsiveness. But what was far better was the change in PPV from 6 to 8. And we found a cutoff value of 3.5%, meaning that if you have a PPV of 7% at 6 ml per kilogram, you cannot conclude. But if you increase PPV to 8, tidal volume to 8 ml per kilogram, and now your PPV value is not 7%, but 11%, you can predict that the patient will respond to fluid administration. If PPV increases from 7% to 9%, you can conclude that the patient will not respond to fluid administration. And this test is very helpful because you don't need any cardiac output monitoring device to perform it. And it is very helpful in my experience during COVID-19 pandemic. We use a lot this tidal volume challenge, even in patients with no cardiac output monitoring device. Of course, we also can use passive leg raising test, which can be used in patients with mechanical ventilation as well as in patients without mechanical ventilation. You know this maneuver, which consists in moving the patient or the bed of the patient, not the patient, but the bed of the patient, from the semi-recumbent position to a position where the legs are elevated at 45 degrees and the thorax and the head are horizontal. And this is like a free challenge, like a preload challenge. And of course, because the effects are very transient, we need a real-time measurement of cardiac output to perform this test. And in this meta-analysis, we published with Xavier Monet and Paul Merrick some years ago, we found that in a series of 21 clinical studies, the changes in cardiac output during passive leg raising were highly predictive of fluid responsiveness with a good area under the rocker of 0.95 and a threshold value of 10%. So if during PLR, passive leg raising, cardiac output increases by more than 10%, you can be almost sure that the patient will respond to fluid administration, and the opposite is true. And it works very well in patients with ARDS, and again, far better than pulse pressure variation. So after assessing the numerator of the benefit-risk ratio, you also have to assess the denominator, the worsening of lung edema. So how to assess the risk of pulmonary edema? Can we use PAOP, pulmonary arterial occlusion pressure, using a Swengen's catheter? Not really. This is a study comparing PAOP and extravascular lung water in a series of critical ill patients. As you can observe, there is no correlation. And for a value of 12 meters of mercury of PAOP, you can have a low, a medium, or a very high value of extravascular lung water, meaning that you cannot rely on PAOP to estimate the degree of pulmonary edema. So it is better to directly assess the risk of pulmonary edema by measuring extravascular water or estimating extravascular water. As you know, it is possible to do this using a transpulmonary thermodilution system, which can provide a quantitative measure of lung edema by providing the value of extra strong water. And in this study, performed in very severe ARDS patients with Mathieu Josiac and Xavier Monet, we showed that extra strong water was an independent predictor of mortality in ARDS patients, in very severe ARDS patients. Therefore, we can try to use it at the bedside to estimate the risk of pulmonary edema. Another parameter which is interesting to look at is PVPI, which is a pulmonary vascular permeability index, which can provide a quantitative marker of lung capillary leak. And also, it was associated in this study with mortality, independently of other variables. Therefore, it is very interesting to look at in ARDS patients. This slide presents results of data we observed in COVID-19 patients. This study was submitted but not yet accepted. We looked at the values of extra strong water and pulmonary vascular permeability index in 45 patients with COVID-19 ARDS. And we looked at the worst PF ratio during the stay of the patient, less than 100, between 100 and 200, and between 200 and 300. So we can define severe ARDS patients in the majority of cases, 27 of cases, moderate ARDS and mild ARDS. And we measure the value of extra strong water indexed at the lowest PF ratio, and we observe different values of lung water. For example, for severe ARDS patients, we found sometimes a value of lung water more than 25, which is a very high value. The normal value is less than 10. In some patients, we observe this high value, meaning that the fluid infusion is very risky in these cases, and this even in case of shock or pressure responsiveness. So it is important not only to predict fluid responsiveness, but to look at the risk of lung tolerance of fluid infusion. But sometimes we have low values or not so high values of extra strong water, between 10 and 15, for example. And in these cases, fluid infusion can be attempted, and especially in case of shock and pressure responsiveness. So in my opinion, it is very important to look at the values of lung water, because even in case of shock and pressure responsiveness, it can indicate what is the best way to do. Also, in this series of patients, we looked at the values of pulmonary vascular permeability index, measured at the lowest PF ratio. And again, we have different patterns about PVPI. In some cases, we have a very high PVPI value, meaning that fluid infusion is highly risky in these patients with high lung water and high permeability, and this even in case of shock and pressure responsiveness. And sometimes we have not very high values of PVPI, and in these cases, fluid infusion should be attempted because of the presence of low PVPI and in general low extra strong water. So these systems, transpulmonary thermodilutions, can be very useful for guiding fluid management, especially in the presence of ARDS and shock, septic shock, because they can well assess the fluid infusion benefit risk ratio. They can assess the benefit by pulse pressure variation before or during a tidal volume challenge, but also by the pulse control cardiac output response to passive lag rising and to end expiratory occlusion test. And this can be good to assess the numerator of the benefit risk ratio. And the denominator can be assessed by the values of extra strong water and pulmonary vascular permeability index. So it is very easy to make the decision to start, to continue, or to stop fluid infusion. And this is why the ESICM, the Open Society of Interventional Medicine, and its cardiovascular dynamics section proposed, in case of ARDS and shock, to use either transpulmonary thermodilution systems or pulmonary artery catheter, especially in the case of RV dysfunction. So if the decision of fluid infusion is made, which type of fluids should we administer? What are the recommendations of the Surviving Sepsis campaign? They recommend using crystalloids over colloids. It is a weak recommendation, but it is a recommendation. They suggested balanced crystalloids over unbalanced crystalloids. Still a weak recommendation. They recommend against using starches. They suggest against using gelatins. They suggest against using dextrans, and they suggest against the routine use of albumin for initial resuscitation. So these recommendations are more or less similar to the recommendations for non-COVID-19 patients. What about vasoplegia, which can be also a mechanism for hemodynamic instability? As you know, there are many patients who are ventilated with high dose sedative drugs to adapt the patient to the ventilator. And also, there is sometimes the presence of associated septic shock, and these two conditions can lead to vasoplegia. And a way to diagnose vasoplegia easily at the bedside is to look at the value of diastolic arterial pressure, because, as you know, the diastolic arterial pressure is a marker of low vascular tone, and especially in patients with tachycardia. And therefore, just at a glance, you can diagnose vasoplegia and you can propose vasopressors, of course. And in this Chinese study, around 35% of patients received vasopressors, essentially norepinephrine. And this can be given, vasopressors can be given even before fluid administration to counteract the effect of sedative drugs. And it is very frequent in these COVID-19 patients. So norepinephrine is the first line vasoactive agent recommended in case of COVID-19 with shock. And for other patients, for COVID-19 patients with shock, they also suggest adding vasopressin as a second line agent over titrating norepinephrine dose if the target MAP cannot be achieved by norepinephrine alone. Again, this is a weak recommendation, but we have to think about some trials comparing vasopressin and norepinephrine. For example, this published last year, it was a randomized controlled trial performed in septic shock patients with cancer. It was performed in Brazil, and Ludmila Ajar was the first author, and they did not find any difference between vasopressin and norepinephrine. And also, we just remember this trial published last year. It was a Sepsis Act randomized controlled trial comparing, again, norepinephrine to not vasopressin, but to celepressin, which is a highly selective V1A receptor of vasopressin. And there was no difference in terms of free of ventilation and vasopressors days, and no difference in mortality. So probably celepressin or vasopressin are not the magic agents, but they can be given as a second line agents when norepinephrine is not able to achieve the MAP target. Also, the Surviving Sepsis campaign recommends or suggests the use of low-dose corticosteroids over no corticosteroids in case of COVID-19 and refractory shock, just to reverse shock. So again, it is a possibility in addition to norepinephrine in case of refractory shock, or in addition with a combination of norepinephrine and vasopressin. And is there a place for angiotensin II in COVID-19 patients? You know that angiotensin II is another vasopressor, which was demonstrated to be better than placebo in septic shock patients. It was the ATOS study. And maybe in the case of COVID-19 could be an interesting drug because of the mechanism of action. Just remember that this angiotensin II is able to fix the angiotensin II receptor at the surface of the vascular cell, and this can create vasoconstriction. This is a way to increase blood pressure. But don't forget that the SARS-CoV-2, this virus, this terrible virus, is able to enter the cells of the patient by fixing
Sí, se ha parado un momento, por favor. A nuestros participantes, y estimados participantes, el doctor Tebul aparecía teniendo dificultad técnica y ha salido. Espere un momento, por favor, a que retorne. Jorge Watanabe.
Sí, sí.
Sí, tenemos un problema con el profesor Tebul que ha salido de la plataforma. Estamos esperando a que retorne. Le pedimos a los participantes que espere un momento, por favor, a que el doctor Tebul retorne a la plataforma.
Más bien,
Gracias.
si hubiera alguna pregunta, los participantes lo pueden ir escribiendo en el chat para ir teniendo más o menos definido las preguntas que tienen con lo que está avanzándose en la ponencia. Esperemos que el profesor se conecte.
Pueden hacer sus preguntas a través del icono de preguntas y respuestas que ustedes tienen abajo. El chat está deshabilitado, sino todas las preguntas y respuestas es a través del icono de preguntas y respuestas. Al costado van a ver también un icono de votación, que al finalizar la conferencia ustedes van a poder, de alguna manera, ver y calificar la calidad de esta presentación. No levanten la mano, por favor, porque no vamos a poder darles el pase, porque solamente son los panelistas y el profesor que está en cámara. Todas sus preguntas a través del icono de preguntas y respuestas. Abajo tienen ese icono. Gracias a los que están ya respondiendo. Jorge, no sé si te puedes comunicar con el profesor de repente por WhatsApp o por teléfono. Ok, el icono de votación va a salir al final de la conferencia. Pueden seguir avanzando con las preguntas. Jesús, Rosita, no sé si están en el foro todavía. Jesús, Rosa.
Sí, doctor. Sí, estoy ahí.
De repente podemos ir avanzando con unos comentarios del avance de la presentación del doctor Jean Luis. Rosita. Jorge.
Uno de los problemas que vemos con frecuencia en los pacientes que están en ventilación mecánica es la sedación que trae consigo marcada inestabilidad hemodinámica, ¿no? Entonces, siempre estos pacientes están con vasopresores y a veces hacemos la fluidoterapia en la medida de que se vaya compensando, pero a veces la persistencia, el shock, considero que de repente no se puede llegar a una fluidoterapia óptima y de alguna manera yo creo que es responsable de la falla renal que en muchos pacientes se ve, en los pacientes con COVID-19, ¿no? Es muy difícil, digamos, poder definir qué nivel óptimo de fluidoterapia podemos tener. No sé si Jesús o Rosita tienen alguna experiencia respecto a lo que es fluidoterapia.
Ahí está todo. Ahí está todo.
Ya está, queremos.
Sí.
Ok.
Can you hear me?
Ok.
Yes, professor.
I'm sorry, I was disconnected.
No problem, professor.
May I finish?
No.
Okay.
It's okay.
Can you see? Can you?
Yes, yes.
Okay. So I am very sorry, I was disconnected. I just continue and almost finished my presentation.
Okay, thank you.
Another recommendation of the SSC guidelines dedicated to COVID-19 is to titrate vasoactive agents to target MAP between 60 and 65 meters of mercury. I don't fully agree with recommendation because 60-65 seems to be very low, and it is assumed that one size fits all. That is to say, we have the same target for everyone. It is probably not true in all cases, and in particular in cases of patients with history of chronic hypertension. As you know, in these patients, maybe we could have a higher MAP target. This is a study we performed in France with Pierre Asfar and others. It was a multi-center randomized controlled trial comparing in septic shock patients two targets, two MAP targets. One was 65-70 and one was 80-85. And we did not find any difference in terms of mortality, but we found better kidney function with a high MAP target between 80 and 85 in patients with chronic hypertension. Probably in these patients, there is a shift to the right of the autoregulation curve. You know, this relationship between MAP on the x-axis and organ blood flow on the y-axis. In patients with no prior hypertension, probably 65 is okay because it is on the plateau on the relationship. But in patients with chronic hypertension, because of the shift of the curve, a value of 65 is not enough, and we have to increase MAP to be on the plateau of the relationship. Therefore, in patients with chronic hypertension, we need a higher MAP target than 65. Another case is high CVP, high central venous pressure. Because as you know, what is important for organ perfusion is not only MAP, which is considered the upstream pressure for organ perfusion, but also CVP, which is the outstream pressure for organ perfusion. And therefore, what is important is the difference, MAP minus CVP, which is called the mean perfusion pressure. And in this study by Marius Osterman and co-workers, they found that mean perfusion pressure, the difference between MAP and CVP, but not MAP, was an independent factor associated with acute kidney injury progression. And they found a value of 60 meters of mercury as a cutoff. Therefore, if CVP is high, which is possible in COVID-19, because I told you that in many cases you have RV dysfunction. So if CVP is high, it is important to increase MAP in order to have a difference of MAP minus CVP of at least 60 meters of mercury. So my first conclusion is we have to personalize the assessment and the therapeutic decision for COVID-19 patients in terms of hemodynamic management. The decision of fluid infusion should be considered in cases of hemodynamic instability with organ failures and a benefit of fluid responsiveness higher than the risk lung tolerance, and the decision of fluid depletion should be considered in cases of severe hypoxemia, fluid unresponsiveness, and presence of high extracellular water of high degree of pulmonary edema. Regarding vasopressors, the decision of norepinephrine infusion should be made in cases of low diastolic arterial pressure, even at the early phase of the disease. The MAP target should be individualized, and just think about patients with chronic hypertension, which are very frequent in case of COVID-19, as you know, because it is a risk factor of COVID-19. Also take into consideration high CVP, because it is very frequent in case of COVID-19. In case of high CVP, we have to consider the difference between MAP and CVP. And also think about the possibility to use vasopressin as a second-line agent. Don't forget to exclude massive pulmonary embolism or myocarditis as potential causes of shock, of course. And here, there is a major place of echocardiography. I would like to thank you very much for your attention. And if you have questions, I'm very happy to answer. Thank you very much.
Muchas gracias, doctor De Bull, por su brillante exposición. La primera pregunta que le haría es, ¿cómo podemos optimizar la fluidoterapia en los pacientes que están con una sobresedación? ¿En qué medida podemos regular la fluidoterapia en estos casos, ¿no? Porque es por vasoplegia o es por déficit de volumen. ¿Qué método sugiere usted para optimizar la fluidoterapia en los pacientes con sedación?
I can't hear you, sorry, I can't.
Jorge, tiene que traducirle la pregunta al profesor.
I cannot hear you, sorry.
Ok. Ok. Entra al auditorio principal, inglés, para que te escuche y ya traducimos, ya no simultáneo, sino en secuencial.
Sorry, I cannot hear.
Tienes que entrar, Jorge, al panel de inglés. Cambia o apágalo. Apaga ya el canal de español. No te escuchamos, Jorge.
Poco. ¿Te escuchamos? A ver.
No, en el sistema Zoom tienes que entrar a inglés para poder escucharte. O apaga el canal. Hay un punto ahí donde dice interpretación, apágalo. Dice inglés-español, apágalo. Jorge, de repente si hacemos alguna otra pregunta mientras esperamos a
ver.
Jorge Cabrera.
Estamos viendo algunas preguntas del público. Básicamente, cómo regular los vasopresores en los pacientes que están digamos, con inestabilidad hemodinámica, de alguna manera para poder regular también o evitar la falla renal en los pacientes con falla, ¿no?
I have no translation, but I think that you speak about vasopressors in case of renal failure. This is what you mean, or I don't know.
A ver.
I did not very well understood. I did not very well understand the question. Vasopressors.
Okay. Rosita, ¿puede hacer la traducción?
I'm no translation, but
sorry, I had to be out. Would you please repeat, Dr. Tibul?
I have no translation, so I did not well understand the question.
Okay. Now you hear me? Now you hear me? Now you hear me?
Yes.
Okay.
Yes.
That's
yeah. Now hear me.
Yes. Now yes.
Yeah. Yes. He's asking you, what is the best method to optimize vasotropics or inotropics or vasoactives to avoid renal failure, acute renal failure?
The issue is that in the case of COVID-19, renal failure is frequent.
En el caso de COVID-19, falla renal es frecuente.
Can be due to hypotension, but not only to hypotension, can be due to other mechanisms. And therefore, it is important to have the best AMAP to avoid worsening of renal dysfunction. But even if you achieve a good MAP, you are not sure to prevent renal dysfunction. Nevertheless, the best way is to achieve MAP target between, I would say, 65 for patients with no chronic hypertension or patients with low CVP, and maybe 75 or 80 for patients with chronic hypertension or patients with high CVP. So it is important to measure CVP to better adjust the MAP, because what is important is the difference between MAP and CVP. So in my unit, we target 65, 70 for patients with no hypertension, low CVP, and more 80, maybe 75, 80 for chronic hypertension and high CVP. Nevertheless, even if you target this best optimal MAP, you can have renal failure due to other mechanisms or renal dysfunction or renal failure in COVID-19. So, because we have some direct toxicity, we also have indirect toxicity on the kidney. So, you cannot prevent all mechanisms, but you have to adjust the best, the optimal MAP.
Sí,
Sí, Coco, ¿te escuchamos?
¿ya? ¿Sí? ¿Me escuchan?
Sí, sí, te escuchamos.
Ya, bueno, dice que la presión arterial media va a depender de cada paciente, va a depender de cada paciente, por eso hablo de la parte de presión arterial media personalizada. Hay grupos de pacientes que no son hipertensos, que ellos van a tener probablemente presiones arterial medias óptimas de 65 a 70 milímetros de mercurio. Pero pacientes que tienen alta PVC o que son hipertensos crónicos, probablemente ellos necesitan presión arterial media más alta. Acuérdate que lo que se busca es presión de perfusión media, ¿no? Entonces, el valor óptimo de presión arterial media va a variar según los pacientes. Por ejemplo, él en su unidad utiliza para pacientes sin hipertensión, que no son hipertensos previos, 65 a 70 milímetros de mercurio de presión arterial media. Pero para pacientes con PVC elevada o con pacientes con hipertensión crónica, prefieren utilizar de 80 a 85 milímetros de mercurio. Si tú has utilizado una presión de perfusión óptima, y hay falla renal, esto ya no depende básicamente de la parte hemodinámica, sino acuérdate que la falla renal puede ser por parte hemodinámica directa o de manera indirecta. Y COVID-19 podría estar, o los fármacos utilizados en COVID-19 podrían estar causando falla renal.
Ok.
Profesor Teúl, Jorgito, sí, quería preguntar, dado que la mayoría de pacientes que tenemos con COVID son hipertensos, ¿no? Y con cierto grado de falla cardíaca, ¿cómo optimizar el estado hipovolémico o pseudohipovolémico en estos pacientes para tener un adecuado manejo hemodinámico en estos pacientes?
Dr. Teúl, do you hear me now?
Yes.
Yes, yeah. How do you optimize the fluid therapy in patients with heart failure and hypertension, which is frequent in this type of patient with COVID-19?
Yes, thank you for the question. Again, I look at the benefit-risk ratio of fluid infusion. So I adjust the benefit, I assess the benefit by looking at fluid responsiveness test. And again, if I have no hemodynamic monitoring device, I use a tidal volume challenge, PPV, pulse pressure variation, and increase in pulse pressure variation after increasing the tidal volume. This is a very, very, very easy way to do, because the patient in general is adapted to the ventilator, as you know. Patient with ARDS and COVID-19 in general is well adapted to the ventilator, and you use high sedative drugs to do this. And when it is adapted to the ventilator, you can use the change in PPV, pulse pressure variation. This is a very easy way to do. So we look at this, and if fluid responsiveness is present, it's not enough to give fluids, because as you said, you can have cardiac failure, you can have pulmonary edema, you can have ARDS, and therefore you have to look at the risk. You have to look at the risk of fluid infusion. So you look at the risk. Either you use, as we use, transparent thermodilution devices, and we look at extra-strong water, we look at pulmonary vascular permeability index, or if you don't use, you have to use your clinical science. You have to look at the degree of PF ratio, etc. And you individualize your benefit-risk ratio. And sometimes you can give fluids in spite of cardiac disease, in spite of ARDS, because the benefit is high. The benefit is high. Just imagine, I told you that during tidal volume challenge, the threshold value is 3.5, meaning that if PPV increases more than 3.5, the patient is fluid responsive. Okay, but what is important is the degree of fluid responsiveness. If PPV increases from 7 to 20, so 13%, it means that the patient is probably very hypovolemic. It's not enough 3.5%. What is important is the degree of increase. So if you have a high degree of increase, high fluid responsiveness, probably you have to think about giving fluids, even if you have cardiac disease, even if you have ARDS, because you can expect a high benefit. And you can increase PVO2 by giving fluids, by increasing cardiac output. And if you increase PVO2, you can increase PaO2. For example, in my experience, we observe patients with low cardiac output, and by increasing cardiac output only with fluid, we improve PaO2, just because we increase PVO2 by increasing cardiac output. So for every patient, you have to individualize, and for the same values of PF ratio, you can have different attitudes due to this individualization. So therefore, we can give fluids to patients with cardiac dysfunction and ARDS, and sometimes we should avoid to give fluids. It depends on the benefit-risk ratio for this individual patient.
Sí. Lo que necesitan valorar es la razón riesgo-beneficio que ella había mostrado anteriormente, ¿no? Ver el beneficio si el paciente tiene un test de respuesta a fluidos y si tiene riesgo si el paciente no tiene tolerancia pulmonar para la administración de fluidos. Lo que utiliza el doctor, por ejemplo, en estos pacientes que están ya sedados, están inclusive relajados, están pegados al ventilador mecánico, el reto de volumen tidal, ¿no? Para ver la variabilidad de la presión de pulso. El punto de corte que él ha mostrado es de 3.5%, ¿no? Si existe un incremento más de 3.5%, ese paciente necesita fluidos y definitivamente hay que darle fluidos. Lo otro hay que ver es cómo se comporta esta variabilidad, ¿no? Si el paciente pues, tiene un 20% de variabilidad, pues tiene gran necesidad de fluidos, hay que darle fluidos de todas maneras. Ojo, pero no solamente queda ahí todo, porque también hay que ver en qué grupo estamos. Acuérdense que él ha mostrado 3 grupos de AR severo, ¿no? Leve, moderado y severo por PAFI. Ojo, pero cada grupo tuvo diferente cantidad de agua pulmonar extravascular y tuvo diferente índice de permeabilidad vascular pulmonar. Entonces, no solamente valoremos la necesidad de fluido en los pacientes en AR, sino luego de dar fluido valoremos qué cantidad de agua vascular, vascular pulmonar, agua pulmonar extravascular tienen y qué índice de permeabilidad vascular pulmonar tienen, ya que podrían caer en mayor riesgo que beneficio.
Rosita, tu pregunta.
Doctor Tebul, muchas gracias por su exposición. Yo quiero traducir una pregunta que está saliendo del común de los intensivistas. Hay 2 o 3 preguntas que van más o menos acerca de lo mismo. Perú es un país muy heterogéneo en cuanto a los equipos y los supplies que pueden tener los diferentes intensivistas en diferentes lugares. No es lo mismo atender un paciente COVID en el Hospital de la Seguridad Social de Lima que atenderlo en un hospital de periferia de Lima o que atenderlo en un hospital de Moyobamba o de Tarapoto. Es muy diferente. Entonces ellos preguntan acerca de las maniobras que con mayor facilidad le pueden ayudar en cuanto a lo que es la respuesta a fluidos y la detección de la titulación de los vasopresores en lugares con poca disponibilidad tecnológica. Jorge, ¿traduces tú?
Pensé que tú lo ibas a hacer.
Ok, no hay problema.
Ya.
So,
Pues, disculpa, como dijiste.
Ya, ajá, ya.
Yeah, Dr. Tebul, what do you recommend us in places where you can find sophisticated devices to do hemodynamic monitoring? What clinical parameters you can say us to try to do the management of our patients?
More exactly, Dr. Tebul, Peru is a very diverse country. So we have people with very few technological equipment, and maybe in the farthest places of our country. So they want to know which maneuvers they can afford in such places.
I understand. I understand. This is an excellent question, of course. I always try in my practice to use clinical parameters, always. My residents, my students prefer to use sophisticated monitoring devices, but I prefer clinical parameters. I look at the color of the urine diuresis. I look at all the components of the pressure, blood pressure, systolic, diastolic, mean, and pulse. And for example, when I have a low pulse, just pulse, systolic minus diastolic, in general, it means that stroke volume is low, cardiac output is low. So it is very simple to do at the bedside, to look at the blood pressure, the pulse. Also the diastolic. The diastolic is a very, very, very easy marker of
hypovolemics.
Vascular tone, diastolic, vascular tone. And it is very easy when you look at the diastolic blood pressure, if the diastolic blood pressure is low, to say, okay, vascular tone is probably low. And this especially in patients with tachycardia. If you have a low diastolic blood pressure and tachycardia, you are almost sure that vasopressors are needed because vascular tone is very low. I use it every day. If you have the arterial line, maybe arterial catheter is possible, even if in low resource settings. Arterial line, you can have pulse pressure variation, not cardiac output, but pulse pressure variation alone. And if the patient is adapted to the ventilator, as I said before, it is very easy to look at the changes in pulse pressure variation, the changes during a tidal volume challenge, as I said before, but also the changes during passive leg raising, just passive leg raising. If pulse pressure variation goes down, probably it means that the patient is fluid responsive. And during the tidal volume challenge is the opposite. If PPV goes up, probably the patient is fluid responsive. It is very simple to do. So I use every day the blood pressure, the pulse, which is a marker of stroke volume, the diastolic, which is a marker of vascular tone, the mean, which is a target for resuscitation. What is better is the mean arterial pressure minus CVP. And also I use pulse pressure variation either alone or during a test. So dynamics of pulse pressure variation during a test, tidal volume challenge or passive leg raising test. And also I look at the urine, at the color of the urine, concentration of the urine. And it can be enough in many cases. In many cases, I would say 85–90% of cases, it can be enough to have an idea of the hemodynamic picture of the patient.
That's so good. Thank you very much. I think it's something that most of our people can be in condition of having. An A-line, a central venous catheter, and the ventilator, and of course, the intensivist beside the patient.
¿Traduzco?
¿Traduces?
Sí, el doctor Tebul dice de que es cierto, es una realidad, que muchas cosas, él prefiere utilizar a veces parámetros clínicos, a diferencia de sus residentes que les gusta utilizar dispositivos bastante sofisticados. Él los aborda inicialmente. Un parámetro para ver es el color de la orina, ¿no? Si la orina está muy concentrada, probablemente este paciente esté hipovolémico y necesite fluidos. Otro parámetro que él utiliza es la parte de la presión arterial sistólica, la presión diastólica y la presión de pulso y la presión media. Entonces, los pacientes que tienen una alta, por ejemplo, el paciente que tiene una diferencial corta, una presión de pulso corta, ese paciente probablemente sí necesite volumen. No, un paciente que tiene una presión diastólica baja, con una diferencial amplia, ese paciente lo más probable es un buen indicador de la diastólica baja de vasodilatación, ¿no? Y si el paciente tiene diastólica baja y está taquicárdico, es bastante, pero bastante probable que ese paciente vaya a utilizar vasoactivos. ¿Qué más comentó? Ah, ya. Y lo otro es que ya sea que estén en cualquier lugar o un lugar alejado, siempre está disponible una línea arterial, ¿no? Para que midan ustedes y vean casualmente ese tipo de parámetros. Y en la medida posible, si pueden utilizar, y acuérdense que las presiones de perfusión van de acuerdo, no es lo mismo presión arterial media que presión de perfusión media. Entonces, hay que tomar en cuenta los valores de presión de perfusión media cuando uno quiera escoger valores de presión arterial media. Y para eso tienen que restar solamente la presión arterial media de la presión venosa central. ¿Sí?
Hay
una pregunta más acá, ¿puedo hacerla?
Sí, claro.
¿Sí? Doctor Banzan, could you briefly explain the main difference in the hemodynamic impact of mechanical ventilation in COVID-19 based on physiological principles, a difference phenotypes according to Gattinoni, and how should we address them?
It's a difficult answer. Good question, but a difficult answer because the two phenotypes described by Gattinoni are not always present. I would say sometimes you have a change from one phenotype to another phenotype. So you have to assess every day. You cannot consider that a patient has a phenotype and will not change. So this is one part of my answer, because I saw many COVID-19 patients with ARDS, and I think that this separation in two phenotypes is too, how to say, is too, probably not the reality. The reality is in the medium. There is some continuum between one phenotype to another phenotype first. And in terms of heart-lung interaction and this kind of phenotypes, the physiology is the same. So we use mechanical ventilation, for example, to assess hemodynamics by pulse pressure variation, by index perturbation test, by tidal volume challenge, whatever the phenotype. It works in any phenotype. But again, I'm not a believer of two different phenotypes. There is a continuum between the two phenotypes, and one patient can change from one day to another day. And this is my answer for hemodynamics. So there is no difference in terms of assessment of hemodynamics using mechanical ventilation on the presence of one phenotype or another phenotype.
El doctor nos ha dicho de que en realidad los dos fenotipos no son estáticos, ¿no? Pensar que el paciente puede pasar de un fenotipo a otro fenotipo rápidamente de un día para otro. Y que lo más frecuente es que el paciente se encuentre en el medio en realidad. Cuando los pacientes que ha visto en ventilador mecánica, ¿no? Y la variabilidad es de un día para otro. Y el abordaje hemodinámico es el mismo. No piensen que el paciente se va a quedar en un solo estado. El paciente es variable, el paciente es dinámico y varía en el tiempo, ¿no?
Hay una pregunta, bueno, es un aporte del doctor Jesús Jauregui, nos dice el uso del gap de CO2, la extracción de oxígeno, la saturación venosa central para guía y monitoreo hemodinámico se debería también hacer en pacientes con shock séptico, obstructivo, cardiogénico y en COVID. ¿Qué opinión merece, profesor, sobre este punto?
Doctor, what is your opinion about gap CO2 in these patients to hemodynamic monitoring in this kind of patient with COVID-19?
So for me, there is no difference between COVID-19 and non-COVID-19 patients regarding the interpretation of PCO2 gap. It is the same for me. Physiology is the same, whatever the disease. And the meaning of CO2 gap is in almost cases when you have an increase in CO2 gap, for example, when you have 6, 7, 8, 9, 10 milliliters of mercury of CO2 gap, this CO2 gap is a difference between PCV CO2 and PSO2, sorry, PSO2. So when you have, for example, 8, it means that cardiac output is not enough, is not adapted. And you have to increase probably cardiac output to improve hemodynamics. So it is a way to assess the adequacy of cardiac output to metabolic conditions. And this is not different in COVID-19, in my experience, but this is physiology, in COVID-19 and non-COVID-19 patients.
La interpretación del gap CO2 en pacientes no COVID y en pacientes no COVID es la misma, la fisiología en ese aspecto es la misma, ¿no? Tiene la misma interpretación.
Hay una pregunta específica, dice, y en caso de una paciente con preeclampsia severa y que está con cuadro severo de COVID, si tuviera alguna recomendación especial.
No, disculpe, me distraje. ¿Qué pregunta?
Preeclampsia severa,
Ya.
paciente con preeclampsia severa, con COVID severo en máquina, ¿qué consideraciones hemodinámicas deberíamos tener?
Dr. Tebul, in patients, in pregnant patients with COVID-19 and mechanical ventilation, what hemodynamic considerations would you tell us?
I cannot answer this question because we did not admitted any pregnant patient in our ICU for COVID-19. Fortunately, I would say, fortunately, so I have no experience with this kind of patients with COVID-19. I am very sorry.
Pacientes gestantes. Se lamenta, pero no ha tenido pacientes gestantes en su servicio.
Ok. Hay una pregunta un poco más encaminada a máquina, pero de repente por la parte de perfusión lo podríamos tomar. Dice, ¿cómo es recomendable realizar la pronación? ¿Solo 24 horas o tendrá 72 horas, independientemente del PAFI? Recordando que puede producir lesiones, ¿no? Quizás encaminarla al tema hemodinámico. El profesor habló durante su conferencia de que no solamente es ver la parte, digamos, respiratoria, sino también la parte hemodinámica en estos pacientes con disfunciones. Entonces, ¿qué tiempo recomendaría desde la óptica y la perfusión? ¿No?
¿Cómo? Doctor, discúlpeme. ¿Cuál era la pregunta?
La ventilación en decúbito prono está orientada básicamente a la parte respiratoria, ¿no? Para mejorar el PAFI, entre otras cosas, y el reclutamiento. La pregunta es desde el punto de vista de perfusión, que el profesor justamente habló en su conferencia, que también tiene una mejora. ¿Cuánto tiempo, desde el punto de vista de perfusión, él lo recomendaría?
Dr. Tebul, in proposition, you have we have a better hemodynamic profile, no? But with how much time do you recommend proposition? Waging the good performance of hemodynamic perfusion.
So prone positioning is a treatment for ARDS, for hypoxemia, of course, of ARDS. It's not a treatment for hemodynamics. But what I said and what we published already is that we can improve hemodynamics also in addition to improvement in blood gases, especially in patients with right ventricular dysfunction, RV dysfunction, which is the case in many patients with COVID-19. And this effect, we observe this effect after 1 or 2 hours of prone positioning. But of course, we did not assess the effects after some hours because the situation, the hemodynamic situation probably changed. It's difficult to look at the effects, the long-term effects. Nevertheless, I think that these effects, hemodynamic effect, can be maintained for all the duration of the prone position session. Nowadays, it is recommended to use longer prone position sessions. And in a paper recently published in Annals of Intensive Care, it was proposed to prolong for more than 16 hours, probably 20 or 24 hours for the lungs, not for hemodynamics, of course, for the lungs, for improvement in the lung mechanics and the lung blood gases. But for hemodynamics, I would say that if you observe a good hemodynamic response after 1 hour, you can probably have a good, also a good response after some hours. But we did not assess after hours, but just after 1 or 2 hours.
Bueno, ART, en primer lugar, PRONO se ha diseñado para ARTS y para mejorar a los pacientes con ART, que es una manera de reclutar el pulmón. Lo que se ha estudiado es el efecto hemodinámico del paciente con ARTS en prono, como estudio adicional de lo que pasa en los pacientes con ARTS pronados. Y sí, hay una mejora hemodinámica, sobre todo en los pacientes que tienen disfunción del ventrículo derecho. Él lo ha analizado hasta 1 a 2 horas de la mejora de esta disfunción, de esta mejora hemodinámica, ¿no? Sobre todo para el ventrículo derecho. Pero no los ha seguido más tiempo. Asume que los pacientes que se benefician, que tienen este beneficio hemodinámico, se mantiene más allá del tiempo que se está estableciendo, ¿no?
Interesante. Rosita, prende tu micrófono, por favor.
El doctor Watanabe ha tenido un impasse con su conexión de internet. Vamos a continuar la moderación. Para aclarar, hay muchas preguntas en el chat acerca de la charla, en dónde va a quedar colgada después. Recordarles que va a quedar colgada tanto en la página web de SOPEMI, como en la página de Aspefam, como en la página del Facebook Live SOPEMI, para que puedan volverla a escuchar. Hay una pregunta del doctor Carlos García Santillán, que voy a leer tal cual. Profesor Tebul, in the acronym ROSE of the fluid management in shock, in the deresuscitation phase, do you have any consideration or use of the VEXUS protocol, the use of venous Doppler of the suprahepatic veins? Para traducir para el resto, en el acrónimo ROSE del manejo de fluidos en shock en la fase de deresuscitación, ¿tiene alguna consideración por el uso del protocolo VEXUS, el Doppler venoso de las suprahepáticas? Go on, Professor Tebul.
Yes, thank you for the question. I have no experience about this, but what is important for the resuscitation phase is to estimate the degree of fluid overload. So personally, I use the lung water, extra lung water, but also you can use the Doppler of the hepatic vein and to look at the degree of fluid overload. So it's not how to say, it's not illogical. It could be logical to use this if you cannot use other devices. But of course, you have to assess fluid overload, maybe by this technique, but you also have to assess, how to say, the degree of fluid unresponsiveness, because you can have fluid overload and fluid responsiveness sometimes, of course. We have some patients with hypovolemia and edema, peripheral edema. Sometimes we have to give fluids because of hemodynamics, and sometimes we have to avoid to give fluids. So it is important, if you want to de-resuscitate the patient, to be sure that not only fluid overload is present, maybe by Doppler, but that the patient is not fluid responsive anymore. So it is very important. Two are important, not only fluid overload, but fluid unresponsiveness. This is my answer. But hepatic veins and Doppler could be a way to assess fluid overload, of course.
Traduce, por favor, Jorge.
Lo importante, dice acá, es importante y es lógico tener este tipo de dispositivo Doppler o ecografía para poder valorar la fase de resucitación, ¿no? Que él, sí, son otros instrumentos más que están a la mano para poder valorarlo. Él utiliza dispositivos de termodilución para valorar, ¿no? Pero le parece lógico el uso y que hay que la idea es que cuando tú utilices este tipo de dispositivo, evalúes que el paciente no lo lleves a la fase de respondedor a fluidos, sino que se quede en la fase que no es respondedor a fluido, porque si no, al contrario, te estás yendo hacia la hipovolemia, ¿no? Ese es el objetivo en esa fase, independientemente del dispositivo que utilices.
Claro. Tenemos la pregunta del doctor Jaime Hidrobo. Saluda, doctor Tebú, y nos dice, en su experiencia, el aumento de ácido láctico asociado a uso excesivo de catecolaminas tiene un comportamiento diferente entre los pacientes con shock séptico por SARS-CoV-2 de los que no lo son.
Ácido láctico y catecolaminas, ¿no? ¿Cómo dijo?
Si los pacientes con ácido láctico implementado y que están con uso de catecolaminas, ¿no? Con exceso de catecolaminas, si tienen un comportamiento diferente entre SARS-CoV-2 y los que no lo tienen. Si hay una diferencia.
Doctor, exists any difference between the patient with septic shock with high doses of hynotropic and lactacidosis from the patients with COVID-19? In both cases, both behaved the same?
Sorry, I don't understand the question.
Patients with septic shock.
Yeah.
With lactacidosis, high dose of hynotropics. And the patient with COVID-19 and with high levels of lactic acids, or high lactacidosis, and high doses of hynotropic. Both groups behave the same or different?
I'm not sure to have understood the question. Nevertheless, high lactic acidosis or hyperlactatemia in general is not due to vasopressors, except if you use epinephrine, adrenaline, because the effects of catecholamines on lactate depends on beta-2 receptors, not beta-1 and not alpha receptor, beta-2 receptors. So all the drugs that act on beta-2 receptors, for example, epinephrine can create some hyperlactatemia. But if you use norepinephrine, if you use dobutamine a little, because dobutamine acts on beta-2 receptors, but norepinephrine don't act on beta-2 receptors. So normally you should not have high lactate due to catecholamines. But I'm not sure that it is your question. I did not understand very well the question. I'm not sure this is the answer you are expecting. But there is no difference between COVID-19 and other septic shock for this. There is no difference.
No hay diferencia en realidad entre COVID-19 y COVID-19 y shock. Pero sí los niveles elevados de ácido láctico son debidos, siempre y cuando se utilice adrenalina, ¿no? Epinefrina. ¿Por qué? Porque actúan sobre receptores beta-2. Pero norepinefrina actúa sobre alfa y beta-1. Entonces, no sería justificado que produzca un gran elevado valor de ácido láctico, una hiperlactacidosis, ¿no? Y que la dobutamina, dosis leves o moderadas, tampoco. Pero ya a dosis mayores sí, porque sí actúan sobre los receptores beta-2. Pero que él no ve ninguna diferencia entre el comportamiento entre shock séptico y COVID-19 en esos casos. Por eso es que no entendía muy bien la pregunta. ¿Está bien, Cira?
Sí. Ok. Tenemos la pregunta del doctor Jesús Enrique, residente de Urgencias de México, y pregunta, ¿cuál sería el mejor fluido en reanimación en estos pacientes, en especial para reducir el daño de glucocáliz?
What is the best fluid to reanimate this kind of patients to avoid the lesion of glucocálix?
First, there is no study about glycocálix and COVID-19 and fluid administration. I would say that the recommendations are identical for COVID-19 and shock without COVID-19. So the recommendations of the SSC, Surviving Series Campaign, is to use crystalloids, to use balanced crystalloids over non-balanced crystalloids. And they said that at the beginning of the disease or beginning of shock, they suggest not using albumin for the initial resuscitation, but maybe later using albumin. And we know there are some papers that show that albumin is able to preserve glycocalyx, is able to preserve more than other solutions. There are some papers about this, not in COVID-19, but in other situations. So maybe albumin is not so bad for glycocalyx. Nevertheless, the recommendation is not to use albumin for the initial resuscitation, but to reserve albumin for later phases.
Bueno, no hay, dice que la albúmina no está indicada ahorita para la resucitación inicial en este grupo, en realidad en cualquier grupo de pacientes, ¿no? En la fase inicial de resucitación no se debe utilizar albúmina. Dos, que no hay estudios ahorita de tipo de fluido, ya sea un balanceado o no balanceado, de cristaloides balanceados o no balanceados, para que produzcan mayor o menor lesión en el glicocáliz, sobre todo en estos pacientes que tienen COVID-19, ¿no? Y que la recomendación es la misma, ¿no? Utilizar cristaloides.
El doctor Gustavo Nasí pregunta si en su unidad, el doctor Tobú, si usan si usan la ecografía transesofágica para sufrir la mala ventana de ecografía que tienen los pacientes que usualmente son obesos, en pacientes en máquina con COVID.
Dr. Tobú, do you use echocardiography, esophagus echocardiography to avoid the bad window of the chest?
No, because there is a risk of contamination, of doctors and nurses. So we in our experience, we never use transesophageal echocardiography. We do not put a probe in the esophagus as we do in other categories of patients, of course. So we used only transthoracic to avoid contamination.
No, el doctor no utiliza ecocardiografía transesofágica porque para evitar contaminar al personal, los médicos y enfermeras. Lo que él utiliza es ecocardiografía transtorácica.
Bien. Rosita.
Bueno, estamos llegando al final de estas casi 2 horas de transmisión. Muchas gracias por su asistencia. Vamos a darle pase al doctor, en primer lugar, al doctor Jesús Valverde para las charlas de las PERLs, de toda la charla del doctor Tebul. Doctor Valverde.
Bueno, yo quería agradecer al profesor Tebul porque siempre tiene disponibilidad de atender a las invitaciones de SOPEMI. En estos momentos nos encontramos en una situación bastante delicada en Perú. Necesitamos el apoyo científico de todas las personalidades a nivel del mundo para poder asumir esa responsabilidad que estamos teniendo acá. La charla de hoy día ha sido muy académica, muy científica, como siempre ha sido en la calidad de presentaciones del profesor Tebul. Hemos aprendido varios puntos, varias perlas. Sobre todo me pareció interesante el monitoreo de la presión arterial diastólica, ¿no? La diferencial para poder optimizarlo con vasopresores, ¿no? El uso de fluidos, ¿no? La necesidad de utilizar clínicamente también algunos criterios importantes antes que el manejo de, digamos, de técnicas sofisticadas, porque acá en Perú hay una variación importante de tecnología. Finalmente, comprometerlo, doctor Tebul, para el congreso o el curso internacional virtual que va a ser SOPEMI en octubre. Desde ya tiene nuestra invitación, ¿no? Hacia usted. Y pues lo vamos a necesitar más aún ahora que nunca, ¿no? Que nosotros estamos pasando una situación, esperemos que para ese mes de octubre y estemos en una situación mucho mejor. Desde ya también agradecer a Aspefam por siempre el aliado importante para llegar a una plataforma con más de 700 participantes hoy. Al profesor Juan Carlos Mesa siempre por su interés de poder sumar esfuerzos para llevar conocimiento a toda la comunidad científica de nuestro país. Al doctor Miguel Farfán por su colaboración siempre desde Aspefam, y a todos los participantes, panelistas, por su, digamos, disponibilidad de poder asistir a esta charla en horas de la tarde aquí en el país. Un abrazo, doctor Tebul, muchas gracias por su participación, y desde Perú le mandamos un saludo y una invitación para el próximo mes de octubre para poder tenerlo acá en el Congreso Virtual de SOPEMI. Muchas gracias.
Gracias al doctor Valverde. Vamos a darle pase ahora al doctor Miguel Farfán, el director de la Asociación Peruana de Facultades de Medicina, con cuya interacción hemos incrementado mucho estas actividades de educación médica continua para todos nuestros médicos, asistentes y residentes de cuidados intensivos. Adelante, doctor Farfán.
Gracias, doctora Rosa López. A nombre de la Asociación Peruana de Facultades de Medicina, quiero agradecer a SOPEMI, en la persona de su presidente, doctor Jesús Valverde, que verdaderamente en este esfuerzo colaborativo entre la Sociedad Peruana de Medicina Intensiva y la Asociación Peruana de Facultades de Medicina, venimos trabajando en forma conjunta por el bien, yo creo, de la educación médica a todo nivel en el país. Y qué mejor oportunidad que el día de hoy, con esta excelente ponencia del profesor Jean-Louis Tebull, que verdaderamente, como usted dice, doctor Valverde, en una situación difícil, donde las áreas críticas en este momento requieren todo el apoyo, el conocimiento, la transferencia del conocimiento y la experiencia de otros países, como es del profesor Tebull en Francia. Verdaderamente le quedamos muy reconocidos a SOPEMI y a su persona, doctor Valverde. De igual manera, a los moderadores, al doctor Jorge Watanabe y al doctor Juan Carlos Mesa, verdaderamente por la forma como han conducido las preguntas y han moderado esta excelente charla académica, a nuestros intérpretes, a los speakers, a la doctora Rosa López y al doctor Jorge Cabrera. Muchísimas gracias, verdaderamente, a nombre de la Asociación Peruana de Facultades de Medicina. Muchísimas gracias y buenas tardes.
Muchas gracias, doctor Farfán, y pues desde SOPEMI les damos a todos el más completo agradecimiento al doctor Tebull y a toda la asistencia cuya presencia y cuyas inquietudes nos animan a continuar buscando acercarlos más todos al conocimiento. Dejo finalmente al doctor Juan Carlos Mesa en el cierre del webinar. Muchas gracias a todos.
Okay. Solamente para agradecer a todos los participantes, vamos a lanzar en unos momentos las preguntas, que es un cuestionario de satisfacción de este simposio, y ya para cerrar el sistema, nuestro agradecimiento al doctor Tebull y a todos los participantes y al presidente tanto de Aspefam como SOPEMI de esta alianza que tenemos en este tiempo. Muchas gracias a todos, los ponentes y panelistas ya podrían retirarse sin ningún inconveniente. Muchas gracias, doctor Farfán, doctor Valverde. Vamos a esperar la parte técnica para el tema de la encuesta. Muchas gracias.
Gracias, hasta luego.
Ha sido un gusto. Great to see you, Dr. Tebull. See you again in October, okay?
I hope. Thank you very much. Thank you to everyone. And
okay.
I hope the best for the patients in Peru, in the rest of Latin America, and I hope that this terrible pandemic will finish and we can communicate face-to-face next time. Thank you very much for the organization of this webinar. Thank you, Dr. Valverde. Thank you, Dr. Rosa Lopez. Thank you, Dr. Mesa. Thank you, my translator. Thank you for the translation. And thank you, everyone, for listening. Thank you. I hope to see you
our
face-to-face very soon.
See you then.
Bye. Bye-bye.
Bye.
Bye-bye.
Bien. A los participantes van a salir ahora una encuesta, por favor. Resuelvan brevemente qué es el control de asistencia. Muchas gracias.
Gracias.